Good afternoon, everybody. Welcome to today's webinar. I hope everybody is well and keeping safe and doing their damnedest to keep themselves and their families protected. Today, SafMed has kindly sponsored our webinar again. This new webinar series that we are presenting now is going to be hosted by myself, Sana Jardine. Of course, SafMed has been your preferred supplier, hopefully, for the last 30 years in the environment of theatre and CSSD. In the webinar series, there are 4 series now. We'll run them every 2 weeks. The first one being today, we are going to talk about sterility assurance and the concept of sterility insurance. In the second webinar, we'll talk about the role of sterility assurance in preventing surgical site infections. And in webinar 3 and 4, we'll talk about all the items that we need to be able to monitor sterilization. For today's session, we're going to focus on a few concepts, the first being Spaulding's classification, something that you know a lot about already, but we need to remind ourselves of where we're at. Then we'll learn about the term sterility assurance level, and we'll dive into that in a little bit more detail. We'll look at sterilization and what sterilization validation actually is. Then we've got a section on IQ, OQ, and PQ. Now, those may be terms that are new to you: installation qualification, operational qualification, and performance qualification. And in between, we will review a few journal publications that look at incidences around sterilization and some interesting articles around that. Right, Spaulding's classification. You know it well, or you should know it well. And of course, Spaulding's classification reminds us of how we need to decontaminate our instruments. A device that's coming into contact with intact skin, of course, is a non-critical device, needs to be cleaned. A device that's coming into contact with mucous membranes or non-intact skin is defined as a semi-critical device and requires high-level disinfection. And those devices that are going to be coming into contact with sterile areas of the body or blood, of course, is defined as a critical device and needs to be sterile. But what does sterile actually mean? It's a very good question. We also know that all of those devices that need to be sterilized and need to undergo a whole series or a whole process of steps in order to render them safe to use on a patient. You know, of course, that includes transporting it safely from after use, then, of course, cleaning it properly. We all know the old saying, if it's not clean, it can never be sterile. Then, of course, inspecting it, packing it correctly, loading it into the autoclave or sterilizer, sterilizing it properly, and, of course, then still keeping it sterile after the process, during storage and during transport. A whole series of steps, critical steps, vital steps we need to perform. Today, we need to learn a little bit more and take this a little bit more in depth. What is sterilization? Okay, you all know sterilization is a process, right? And the whole idea is to render a device free from microorganisms. We know that. Okay, cool. But let's take it even deeper. What is sterility assurance? What does that actually mean? And sterility assurance is really about the probability or the chance that a single viable microorganisms actually left on a device after sterilizing it. So what is the chances that we've done all of the steps we were supposed to do, and yet we still have a microorganism that's still alive on our device? And we want to make sure that that doesn't happen. Our entire goal is, in fact, to prevent that from happening. So let's have a look at this table here on the left. We start with the assumption that we have 10 to the power 6, so 1 million microorganisms on our device. And we have to get through this log reduction over here so that at the end of the day, there's nothing left on the device. That's our objective, isn't it? That there's less than 1 or 0 microorganisms left on our device. That's our entire objective. A device, however, that is a critical device, okay, as we've already defined by Spaulding, what is a critical device? It needs a sterility assurance level of even more than that. It needs a sterility assurance level of 10 to the power of -6. So, how do we visualize sterility assurance level? So what we've done is I've put it in a nice graph over here so that we can actually visualize what that is. Right, let's have a look at the graph over here. So the whole idea is actually to visualize a sterility assurance level of 10 to the power of -6. If we look at the red line over here, okay, we've started with 10 to the power of 6, so 1,000,000 microorganisms, and we want to get down to 10 to the power of 0, meaning that there's no microorganisms left on our device. That's our main goal, right? But the guidelines say, no, that's not enough. We have to actually make sure that our sterility assurance level is 10 to the power of -6. So when we're sterilizing a device, we sterilize it for a period of time that it would take for us to get to the level of 0, and then we double that. Now, in a steam sterilizer, under normal circumstances of 134 degrees, that will take it about 2 minutes, that process, to get us over there. But the guidelines actually ask for even more. They ask for safety time or an overkill time. And that means we add another minute to our process over here so that at the end of the day, we end up with a sterile device. And of course, as we said, that's our goal. So the point is that sterility assurance is more than just popping an item into the autoclave and assuming everything's going to be fine. We are really and truly trying very, very hard to make sure, using our sterility assurance level guidelines for a critical device, that our instrument is going to be safe to use on our patient. And of course, our job is to monitor the sterilization process to make 100% sure that we've achieved the sterilization parameters. Now, in the World Health Organization's guidelines for the prevention of surgical site infections, it clearly states there, it is the duty of the sterile services manager or the person in charge of the sterile services department to ensure that a medical device does not leave the unit unless it is completely safe to use on a human. And if it's a critical device, as we've already said, it needs to be sterilized to the correct sterility assurance level. This is our job, this is our responsibility. But how do we do this? And it's not a simple matter of just doing a bioedict test. It's not a simple matter of just doing a biological indicator or looking at the chemical indicator or looking at the process indicator tape. It's way more than that. Again, the World Health Organization guidelines, this one on decontamination and reprocessing of medical devices, states, we have to have a quality assurance or a quality management system in place. And that quality assurance system must incorporate validation of each step of the process. And all of these steps must be documented. All of the records must be kept for at least 5 years. Of course, taking into account your own country's medical legal requirements. What all does validation mean? As I said, this is a process. It's not just one aspect. It's a multitude of things that we need to take into account. It is sterilization monitoring, so using our BRs, using our CRs. It is the product release criteria, so what all do we need to do to make sure that our product is safe before we actually release it from the CSSD? It's record keeping, it's tracking and traceability, it's infection and prevention and control measures that we need to put in place in our CSSD itself. It's the policies and the procedures, it's the education and training. It's the preventative maintenance, it's the auditing process, and it's the knowledge of standards. So these categories that I've summarized over here are obviously covered in a huge amount of detail in our guidelines. Today, or in this series as a whole, we'll look at sterilization monitoring, product release, record keeping, and knowledge of standards. That's basically what will be covered in the 4 webinars that we're doing today. The other aspects we're not covering just yet. So as I said, quality assurance and sterility assurance at the end of the day is a complex integrated process. It's not one thing, it's a multitude of things that we need to do. The other thing the guidelines state quite clearly is that all staff should be trained in the checks to be made before a medical device or a surgical device may be used. Obviously, that includes everybody in the operating room. That includes people who are collecting the packs, transporting the packs before they get to the operating room. And that includes all of us in the CCC. It is our responsibility to make sure the device is as it should be, that it is safe to use when it leaves our department. Let's have a look at this interesting published paper, and this was published in the Central Sterilization Journal. We've spoken about that journal quite a few times in our webinars. This looks at a sterilization investigation in Mongolia. So I chose a country that was relatively close to us. And as you can see, it was in a very strange city. That name I really can't pronounce, but let's have a look at what they had to say in the study. So the goal was to investigate their sterilization processes. This research was undertaken in 77 healthcare institutions, and it included dental practices and some hospitals, obviously areas where they perform surgery. And their main goal was to establish whether or not the sterilizers in these departments would be able to inactivate biological indicators. So would the biological indicator pass or fail in these hospital settings? So they tested 105 steam sterilizers, 3 ethylene oxide sterilizers, 1 hydrogen peroxide sterilizer. And all of this was part of their project because in the country they've got particularly high rates of hepatitis, and they were looking at how the surgical environment could be contributing to the high rates of hepatitis. The Mongolian Infection Prevention Society's Act states that sterilizers must be routinely tested with both chemical indicators and biological indicators. But, as is often the case, the reality is that they're often only tested with chemical indicators, and there is often no routine technical inspection of sterilizers. So this is the findings in this particular paper. At the end of the day, they then tested 187 steam sterilization cycles, 15 EO cycles, and 1 hydrogen peroxide-based sterilization cycle. So they placed biological indicators into loads 187 times, as you can see, 15 times in EO and once in hydrogen peroxide. Also interesting factors that they noticed or they took cognizance of was what year or what dates or grouped in a 10-year period were these actual sterilizers installed. And it was quite interesting. They dated back to 1980. So 7 of them installed between 1980 and 1990. 10 between 91 and 2000, 46 between 2001 and 2010, and 40 between 2011 and 2016, and 2 of them they had no idea. It would be very, very interesting to conduct that same research in the South African setting. I'd really love to know how old our installed base of autoclaves and sterilizers are. Would be very interesting. So what were the results? In total, 8 of the 105 steam sterilizers failed the biological indicator tests. 2 out of 3 of the ethylene oxide sterilizers failed the biological indicator test, and the 1 hydrogen peroxide sterilizer passed the biological indicator test. I guess that would have been a relief. Another point that they noted, of course, is that none of the steam sterilizers had a display or a printer that could be used to verify the process parameters. Again, that display and that printout and that information forms part of the validation of the steam sterilizer. And so it was a little disappointing to note that they didn't even have that. If we go back to quality assurance and validation, remember I said in this webinar, we're focusing a little bit more on the validation of the sterilization process. I'm making the assumption that you all work in CSSD. I'm making the assumption that you have an idea of how an autoclave or a sterilizer actually works. What is validation? Validation is verifying in a certified and a clearly documented manner that a process meets the requirements for which it was designed. So we want to be able to prove that the relevant sterilization parameters were met. So if a device was going in the sterilizer, whether it's steam or hydrogen peroxide or EO, that it was exposed to the sterilant for the right amount of time at the right temperature under the right conditions for that sterilization process. Right, validation of sterilization. 3 important concepts, and all of this needs to be well documented. We need to have performed what is known as an IQ, an OQ, and a PQ. And an IQ is an installation qualification. So again, it's a process of obtaining and documenting evidence that the equipment that was provided has been installed correctly and is safe to operate. So when the device is being installed, did we collect it to the right connections? Do we have the right electricity, water, whatever it is this piece of equipment requires? And is it now safe for us to use? The operational qualification, the formal definition, obtaining and documenting evidence that the installed equipment now actually operates within the specifications that it was manufactured to operate within. So are all the measurements working? Are all the piece of equipment's controls working? So it would include, for example, calibrating your sterilizer. In the case of steam, it also includes the bioedict test. Okay, so moving on to performance qualification. Performance qualification definition, obtaining and documenting evidence that the equipment performs as it should. And in the case of steam sterilizers, for example, we do 3 cycles using a bioedict test and 3 cycles with a biological and a chemical indicator in a loaded autoclave. And part of performance qualification, and even going deeper into that and not really discussing it in great detail today, is about doing worst case load scenarios. So you should actually be putting into your autoclave the worst case scenario. So a really heavy load, a difficult load, making sure then that you're putting in biological indicators, chemical indicators, opening that entire load up to make sure that we actually achieved what we were meant to achieve. So a complex process. If, of course, the autoclave was needed repairs or for any reason there were some issues or you serviced it, you need to perform or repeat some of these processes. So if you look at everything we've said so far, it's really not a matter of just doing a biological, just doing a bioedict, or looking that the tape on the outside of the pack has changed color. This is an in-depth process and one that requires a lot of forethought and a lot of documenting. Here's a paper published in, again, the Central Sterilization Journal, and this is actually one of the recommendations of the Quality Task Group. So this was done in 2013 already. I wasn't able to find a newer version of this particular recommendation, but I think this is quite interesting. Here they speak specifically about the release of medical devices after sterilization. So they're not covering the routine testing. They're just talking about a few factors to bear in mind when you're going to release your items. They say that only experienced personnel may release sterilized medical devices. Of course, they remind us that we need to do visual inspection of the packaging, correct labeling, that you've checked the label on the item. They also use the term process sequence. Remember, this is a German publication, so the English is a little different. And by that they actually meant, once they'd gone into detail, is to make sure that you've selected the correct cycle type. If it's a container load or a load of containers, did you select the container cycle? Do you have a container cycle set up on your autoclave or your steam sterilizer? And also, of course, Did you check process indicators? And did you check the correct batch documentation? Now, we can't do all of that unless we have all of the right equipment and if we have all of the right consumables to do this. Remember that if a pack comes out of the steam sterilizer or the autoclave and the outside tape has changed color, it does not tell me the pack is sterile. It only tells me that that particular pack has been through a process. That's as much as it can tell me. Sterilization monitoring is a complex process. We need to monitor the physical monitoring, the physical monitors. We need a way that we can verify that the parameters were met. And that we'll need to see on the display on the actual autoclave or the sterilizer or the sterilizing process or on the actual printout. Chemical indicators, what do? They verify that one or more of the conditions necessary for sterilization have been achieved at a specific location within the load. What does a biological indicator tells me? It verifies that the conditions at a location within the load were adequate to kill a population of microorganisms that are resistant to that sterilization process, and it demonstrates the lethality of the sterilization process. These are complex processes. There's a whole variety of things that we need to do to be able to validate that we are doing what it is we are meant to be doing. Why? Because it is the duty of the sterile services manager or the person in charge of the department to ensure that the medical device does not leave the unit until it is completely safe to use on a human. I think maybe I'm making my point now, and my point is that this is a complex process, which is why we are going to discuss this over 4 webinars, which is why on webinar 3 and on webinar 4, we'll go into how we go about doing that into a little bit more depth, how we monitor the sterilization process, what we use to do that with, what can a process challenge device do for us, what can a biological do for us, what can a chemical indicator do for us. How do we use them? When do we use them? What are our local country laws and legislations around the use of them? How they're made? And how they need to perform within the standards that they need to perform in. This is a published paper in the American Journal of Infection Control that looked at an outbreak associated with, we know the term is CUSA, so that's an ultrasonic surgical aspirator. A CUSA, for those of you who don't know, is a device that we use often in neurosurgery and all sorts of other types of surgery. I've seen them used often in the South African setting in neurosurgery, of course. It consists of a piece of equipment and a handheld, what is the word? Handpiece, that's the one. And that particular handpiece needs to be decontaminated. There's quite a specific instruction for use on the cleaning and the sterilization of that handpiece. So with the handpiece, you use ultrasonic frequency to emulsify tissues. You then irrigate and suck up some fluid through that actual handpiece. So it can, as you can imagine, get easily contaminated. So in this particular incident, they had this outbreak amongst patients who had undergone craniotomy. Quite a few actually died, not a nice set of circumstances. And after much investigation, the conclusions in the paper were as follows. The outbreak features suggest that the infections were transmitted by inadequate cleaning, as well as suboptimal sterilization. Using these papers and these articles, I'm hoping that I've got through to you the point that sterilization, we know all of the steps of reprocessing are very important. Please, I'm not minimizing any of those, but in this particular webinar series, we're going to talk about sterilization in more depth, what we need to do to validate our processes, what we need to use to validate our processes, and how we go about doing that. As you can see today, I kept our presentation to under 30 minutes. This is micro-learning. I know you guys are busy, so I'm keeping it in short, succinct sessions so that we can learn as much as we can in a relatively short period of time. As a reminder, what did we cover today? We spoke about Spaulding's classification. We reminded ourselves that items that are critical and need to come into contact with the patient's sterile body tissues, need to be properly sterilized to a specific sterilization assurance level. We know that we need to do a whole bunch of stuff to validate this sterilization. We know that we need to do an IQ, an OQ, and a PQ, and we know now from the journal publications that if we don't do what it is we are meant to do, we will not release a device that is safe. We will harm our patients. And that is our entire goal. So we're taking a far deeper look into sterilization assurity and how do we make sure that we provide a safe device from that aspect in this webinar series. So thank you very much for joining us today in our succinct session.